Streaming spine surgery today. We'll be performing a Deuk laser disc repair for the treatment of back and leg pain on a patient who has multiple disc herniations throughout actually the entire spine from L1 down to S1. However, most of the herniations are not causing symptoms. They're not causing any pain. And is it possible for herniations to not cause pain? Absolutely. As a matter of fact, most disc herniations don't cause pain. And that's created a lot of confusion for doctors and healthcare providers figuring out which herniations actually do cause pain. Our patient here has pain in her lower back over the L4-5, L5-S1 and her sacroiliac joints. So we're going to be performing a left L4-5, L5-S1 Deuk laser disc repair. Good morning, Dr. Deuk Majan here. Are you comfortable? Can she hear me? Can you hear me? Perfect. We're going to get started, okay? All right. I'm going to give you some numbing medicine to numb up the skin. You might feel a little stick and burn. If you have pain, just say ouch. All right, and I'll give you some more numbing medicine. Okay? You're going to feel a little pinch and a little burning. That's just the medicine going in. Just relax. You're doing great. How's our blood pressure? Yeah. I'd love it around 110, 100 to 110 if possible. If she can tolerate that. That's just the numbing medicine, okay? It's going to make it feel better in just a moment. I'm sorry, it's a little uncomfortable. All right, so the first thing we're going to do is numb up the skin. We're going in on the left side because it's her left side that bothers her the most, particularly in the leg. It's usually leg symptoms that tell me which side to go on. All right, I've injected 7 cc's of local. Now our target will be the L4-5 and L5-S1 disc, specifically the annular tear and herniation. And it's not going to be easy, I can promise you that. She has very collapsed discs with scoliosis. So we're going to give the medicine a minute and then we're going to get started. Are you comfy? All right. Are your neck and arms comfy? Okay. I apologize. Do we have a warming blanket on this young lady? Good. All right. Yeah, that's just some more numbing medicine. We're going to be able to put you to sleep probably in about 10-15 minutes. I just have to get to where we need to go safely. All right, so let's go with a lateral view. Now we're going to use the X-ray machine views, AP and lateral, which is front, back, and side. We use 2 different views. Sometimes I use an oblique view, but for the most part it's a side-to-side view, which is lateral, and a front-back view, which is AP. All right, let's try to clean that up a little bit. All right, we're a little bit higher than I want to be. Numb. So we're going to go a little bit lower. Just lay still, you're fine. How are things going with her blood pressure? Okay. So the first thing we have to do here is gain access to the foramen at L4-5, L5-S1. I think we need to I'm going to talk to my technician who's controlling the fluoroscope. I think it's not terrible, actually. She does have a little aesthesis at 5-1. I think we're off a little bit. You can kind of see a double shadow on the L5 pedicle. Let's try 1 degree of wag and see what happens. Yeah, we're a little off on orbit as well, but it's mostly the wag. I don't know. I think that's better. But try the orbit a degree. Let's see what happens. So I'm looking at the facets, and they're not really lined up properly. So that's better. That's definitely better. The question is, yeah. All right, it's real important. Don't move, okay? You hear me? All right, you're doing really good. Want to keep it going that way for you, Sean. So I'm touching the facet joints. I may have to come a little bit more lateral for my entry point. And, you know, after doing over 1,300 of these surgeries, honestly, in my opinion, the hardest part is this part, the access to the disc space. If we can just get past this part, then the rest of the surgery goes very smoothly. So, shot. But it's all about getting down to the actual disc and foramen. Shot. I don't know. I think our x-ray is really in great position. I feel a lot of scar tissue here from inflammation around the facet joints and bone. So she's got a lot of arthritis, inflammation here. Shot. How you feeling? Yeah, nothing down your leg, right? Shot. All right. That's good. Let's get a little bit further and we'll get an AP. Shot. We're a little higher than I want to be, but let's get an AP and see where we are. So the L5S1 disc is the hardest to access with a transforaminal approach, which is going through the natural hole that's already open in the spine. As a matter of fact, it's so hard that most spine surgeons that do this kind of surgery, they don't even try to do L5S1. They just try to do other levels like 4-5 and 3-4, but not 5-1. Let's get a shot. I think we're a little bit too lateral. Shot. Let's get lateral. So the reason we stream our surgeries live is for everyone to kind of watch and see how it's done, learn something. The best way to learn is through watching someone do something live. It looks like she's moved. I mean, let's re-wag it because I'm not seeing the pedicles line up properly. Try to lay still, okay? You're doing really good. Yeah, I don't know. I'm not 100% convinced. It's not bad. But let's see if we can get a little bit better. No, I think that's worse. So I'm looking to make sure that we have a really good trajectory to the foramen. What can you do about her blood pressure? Take that. There's epi in here?
Yes, sir.
So we're just infiltrating the skin to reduce any pain she might have. And we put a little bit of epinephrine in our local, which is pretty standard to reduce any bleeding, because epinephrine is a vasoconstrictor, so it causes the little blood vessels to constrict. That way there's no bleeding. But obviously sometimes the blood pressure can be is the opposite of the constriction, so it pushes the vessels open if it's high. All right, let's try this again. How's she doing? Good. Shot. So you see that pedicle double image there at 5? We need to get that fixed. I don't know. I think it's further off, though, to be honest with you. So what we're doing is our patient's staying in their same position, but we're moving the x-ray machine around to try to get a better picture. And some of the challenges, I think that's fine for now. Some of the challenges we have. Shot. What do you feel? Huh? Shot. Just in the back. Shot. Shot. Let's see if we can make her a little more comfortable. AP. What are you giving her for pain? Yeah. Yeah, I'm not surprised. So we've given her a little bit of fentanyl and some Versed to make her more comfortable while we gain access. But this is the hardest part of the surgery for the patient and for the surgeon. Let's go back to a lateral. And it's not just the fact that the disc is collapsed at L5S1. The facet joints are hypertrophied, which means they've enlarged over time, over years of arthritis. We're not treating the facet joints, are we? Oh, we're doing the SI. But what they're doing is they're blocking access to the disc. Where's the AP view? Shot? Mm-hmm. Yeah. I'm sorry, sweetheart. We're trying to get there as painlessly as possible. But this is the part that is uncomfortable. Shot? Then we're going to put her to sleep in a little bit. Shot? Once she goes to sleep, then obviously she won't be feeling anything. But it's just getting to where we need to be. That's the hard part that I need her awake for to help me. Shot. Shot. I really don't want my hand in there. You can't lower the fluoro more? Huh? No.
No, you're good?
Yeah. Just, there's tons of arthritis here. Shot. get another AP. The L5S1 bottom disc is the hardest to get into. Like I said, many surgeons don't even try. They just do L4-5 discs and above. All right, so we're more medial. Go back to a lateral view. Shot. Okay. I need to get out a little bit more lateral. Shot. Shot. No, we're nowhere near her nerve root. Shot. She has a high iliac crest too, which is definitely affecting. Shot. Mm-hmm. Shot. Shot. That's better. Shot. Where do you feel that, Sean? Where? Yeah, we're near that bad disc. All right. Let's get an AP. I'm not convinced we're in the right spot. So by watching these surgeries, you get an appreciation of how difficult it is to do certain parts of the surgery. Namely, the beginning is the hardest part for sure. You know, gaining access to the disc. And where do you feel it? I need to know. Is it back or leg? Where does she feel it? Huh? On her back. Just lay still, Doris. Where? Lateral. Where does she feel it? That time? Mm-hmm. Shot. Where does she feel it now? Let's bring the table up a little bit. Table up 1 inch. That's good. Shot. Does she feel anything now? Where? Where in her leg? Down her leg? How far down? How far down? Well, but we need to know where it goes to. I need her to vocalize that to you. She won't do it on her own. You got to ask her. So I would follow up with, so it doesn't go past your knee. That's what you should say. Yeah.
So does it go past your knee, Doris? Doris? Does it go past your knee? Yes. Okay. Yes.
So that's why it's important to actually get accurate information. Sean? Sean? Where does she feel it?
Doris, where do you feel that?
Sean?
Where? In your leg? In your buttocks? Yes. Okay. Does it go all the way down your leg or just in your buttocks? Doris? Doris? Does it go all the way down your leg?
I would stay off the Versed and just give her a little fentanyl instead, because the Versed is only going to make her confused. Probably.
She said just her buttocks.
Shot? Yeah, because I pulled back. The problem is the needle's being redirected by all the arthritis. It's being redirected too low. Shot? 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 Blood pressure looks good. Because of her high iliac crest, I'm having to try to find a better angle to go in at. Shot? Shot? Somehow we've moved, so you have to get a better job of a lateral shot. Higher. A little bit more medial. Shot. 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 We need to wag. I think we need to wag a little bit. I'm not sure. It's hard to tell if that those pedicles are lined up or not. I don't think they are. No, it's worse. That is better. Don't move, okay? Try to lay still. Shot. 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 Just lay still. You're doing fine. Shot. Yeah. It's arthritis, I can feel all of it here. Trying to get into the foramen. Shot. Very difficult. AP. Let's move it along. Jordan, it should be a quick swing into position. All right, 2 lateral. Back to lateral view. Shot. 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 No, we're nowhere near the foramen. Try a little bit more medial. Shot. 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 Just feel like we're too lateral, or too medial, I mean. Stop. Shot. Really need a good view of that foramen. I think we're close. Give me an AP. For those of you that joined late, AP means anterior posterior. All right. It's not terrible. Let's go back to a lateral. It's just bouncing around that arthritic facet joint. But we're in the right spot. Shot. 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 So there's a very, very narrow window to begin with to gain access to the L5S1 disc. And lay still. And unfortunately, all the arthritis she has in her spine has closed that window up substantially, to the point that, shot, I'm having trouble getting in. And this is right on her iliac crest. So I can't go any lower. I can only go higher. Local. Shot. 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 Let's see, do we sneak in there? So far away. We were so close earlier. We've just gotten further away. Shot by moving around. I don't know if she's moving and changing. It looks like she is. Would you adjust the orbit? It's a little better. Is it? Shot? Yeah. Shot. So close. Let's get an AP. I think we're too medial. So again, for those of you who have joined late, this is the hardest one to gain access to, L5S1. Shot. Yeah, we're too medial. Let's go back to a lateral view. Shot. Shot. And we're coming in at such a steep incline. Shot. I just cannot work around this area. Shot. Let's get another shot. AP. AP. I think I might have to come in a little bit more lateral. See, that's lateral enough. Shot. That's better. Lateral. Again, what I'm encountering, for those wondering, is all this bone and arthritis. We're off on the orbit. Go the other way. Shot. And now maybe the wag. Shot. I think it's a little better. I need her relaxing a little bit more. Shot. AP. So there's a path down to the disc, to the tear that we're trying to fix at L5S1, that's literally as narrow or narrower than this needle. So I have to try to make this work. Shot. All right, lateral. And finding that tiny little path, that little corridor, that passageway, is what we're trying to do right now. But the passageway has been compromised by a massive amount of arthritis that exists here. And I have to work through the arthritis, arthritis is basically enlarged bones, bone spurs, thickened ligaments, and thickened joint capsule. And I have to try to get through all that to get down to the disc. AP. On top of that, she has a high iliac crest, which is pushing my needle at the entry point higher than we really want it to be. All right, so I'm too lateral. I'm sorry, I'm too medial. Let's go back to a lateral view. And shot. Yeah, too medial. Shot. Trying to redirect. Shot. Shot. Just can't get past the bone spurs and the arthritis in the back here at 5'1". It's a bit unusual. Shot. And try going back in through one of these more lateral channels. No, we're just going to go straight into. And if I can't get this, I'm going to have to go just for the L45, which is the other target. So we're trying to fix 2 discs today. It's not often that I can't gain access to a disc, but it does happen from time to time. Shot. 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 Just too far away. All right, let's focus on 4-5. Sorry about that. We're almost going to be done. I've tried to get into your 5-1 multiple times. I'll try again in just a minute, but I'm going to get into the other discs that we're going to fix. Your anatomy just doesn't allow it. Shot. Okay. That's good. You can see the bone spur coming off the back of the L45. We should not need to change our entry point. Shot. 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 Yeah, her. Maybe we do. Maybe a little bit more lateral trajectory would be better. Shot. Shot. Just seems like such a high trajectory than normal. Shot. So we're right by the facet joints now. Let's get an AP. For those of you who don't know what we're trying to do today, we're going into 2 discs to repair them from the back, the L45 and the L5S1. So I need to be a little bit more medial. Shot. Shot. Lateral. And we're using an X-ray machine to guide my path to the spine. Now her spine has obviously some other issues besides disc issues. She has some angulation problems where she's twisted, but we're not here to fix the scoliosis. We're here to basically treat her pain, which I believe is coming from these facet joints. The discs that we're targeting. Shot. What can we do about her discomfort, if anything? She's gonna watch. She's very responsive to me. Use your judgment, but anything you can do would be helpful. Shot. Where do you feel that? She has very short. Shot. Your orbit is off. Shot. I don't know. I think that's better. Go AP now. It's very hard to tell because the patient has osteopenia, osteoporosis. So what we're looking at with the x-ray are bones and the bony anatomy to guide us. But when the bones are thin from osteoporosis, osteopenia, then it makes it harder to use the typical landmarks that we use. So this disc was obviously, if you're paying attention, it's much easier to access than the L5S1. And that's typical. L4-5 is easier than 5-1 usually. But having her moving a bit is also not helping. Shot? Because she's tightening up her back muscles, and that's making it hard for me to gain access to the disc. Shot? You okay? So, trying to walk the tip of the needle right along the top of the bone there into the disc, but it's not wanting to cooperate just yet. And of course, we have that bone spur you can actually see on the x-ray. It's pretty sizable. Shot? Just at the top of the disc that we're going in to fix. Shot? You doing all right? Super? I'm sorry. This is the worst part of the whole surgery. I apologize. We're going to be able to put you to sleep soon. I just want to get everything just right. We're struggling with the bottom disc. I haven't gotten into it yet, but I've spent most of the time trying to get in there. The upper disc is giving me a little bit of an issue, but we'll get there. Don't worry. Shot? I'm just going to try coming in again a little bit higher this time. Shot. Shot. It's like it wants to go, but then it stops. And again, a lot of this is due to her anatomy. She has a very high iliac crest. Very hard to tell ahead of time if patients have a high iliac crest or not. It doesn't look like it on the lateral view, but then we're coming from the back side, so a lateral view doesn't tell you everything. That's where we are?
Yes, sir.
No leg pain, right? Good. So we're in the foramen where we want to be. We're just a little bit lower than I want to be. Where do you feel that? Shot? She's just clamping down. I need her a little more comfortable to relax her muscles and open up the foramen. Shot. But worst case scenario, we could probably work with this. I just won't be able to get my discogram done if I stop here, which is fine. Her discs are pretty collapsed. We're not here to open up her discs. We're here to repair the disc. And the repair that we do really involves debridement of the annular tear and removal of the herniated disc that's there, stuck in the annulus. It's a novel technology and technique, but sometimes, as you can see, give me an AP. We have issues with access. What access means is the getting down to where we have to do the surgery. So it's that part of the surgery in the very beginning where we have trouble getting down to the part of the body that needs to be repaired. In her case, it's her spine, right? Specifically, it's her disc. So the difficulty I'm having is with accessing that disc. Let's go lateral again. So look at the bottom one. The facets are just bulging out to the side up against the transverse process and the sacrum. So I'm going to make one more attempt at 5-1. As far as 4-5 goes, it's like we're right there. Worst case scenario, when she goes to sleep, I could probably put a guide wire down and get into that disc, even though I'm having trouble advancing the needle. And I really wanted her awake for the disc. Oh, there we go. We finally got it. All right. So it was just sitting there, and now we got it. That's great. Did you give her something to relax her a little?
Yes, I said taking
Just recently, though?
yes.
Yeah. So, believe it or not, I know. And you're doing everything right. The patient got a little bit more comfortable. Her muscles just didn't, because if your back muscles are spasming, then what that does is it pushes down on the bones, crushing them together at the disc. So it actually makes it harder for me to get into the disc with a needle. But by giving some pain meds, it relaxed her muscles just enough for me to get the needle all the way into the disc through the annular tear that we're here to fix. You're doing fine. You're doing great. We're going to put you to sleep soon. I just want to try one more time to get to that bottom disc. Sometimes if you wait, you let the patient get a little more comfortable with the anesthetic. That's just my hand, that's all. Don't worry. She's a bit sore in here. That's normal after what we did. I'm just trying to decide where to go. We do have to make an incision, so I might as well do that now. Lay still. We're going to put you to sleep in a few minutes, okay? Now the incision we made is 7 millimeters, and it's really to be able to place the endoscopic tube in. I'm going to try to use the same incision to access the bottom disc. I don't have a whole lot of hope, but I do have some. Shot. Yeah, that bottom disc has been really difficult for us to get into. That's what we spent this whole time trying to do. Huh? Oh, you're welcome. You're going to feel a whole lot better when we're done. I just would love to get that bottom one fixed too while we're here. Now, when a surgeon encounters a problem accessing something or getting the surgery done that they originally intended, they may be tempted to change the surgical plan and do something that was not planned out or discussed with the patient, and that would be the wrong thing to do. I know that's that bad area. Shot. All right. And again, I'm just encountering way too much arthritis. I cannot get through. Yeah. Unfortunately, I just cannot get through. I may be able to get through on the other side. The problem is I didn't discuss that as part of the plan. And what I'm prepared to do is I may have to bring her back at another time to do that. So, all right. We're going to put you to sleep in just a minute, okay? I need you awake for one last part of the surgery. I need your help. I want to make sure we're in the right spot. How bad is that on a scale of 1 to 10? 11. All right. I apologize. We were just testing the disc to see if it was the source of your pain. Is that where you typically get back pain? All right. You get to go to sleep. When you wake up, that pain will be gone for the rest of your life. Sean? Can you count out loud for me, dear? Starting from 1. Count out loud. Yeah, we're ready. Yeah. Once I have them count, that's time to go to sleep. You can actually see the herniation at 4-5. It's got a double shadow there along with that bone spur. You can see the wire going in and you can see the tear. So I attempted L5S1, unsuccessful due to limited access from her anatomical reasons. So my goal today for her was to treat 2 discs, L45, L5S1. Unfortunately, I cannot get to the bottom one. And, you know, I believe the bottom one is causing pain. I believe she'll still have some of her pain after surgery. How much, I don't know. She's also got SI joint pain, which we're treating as well. But I need to see from her how she's doing after this surgery in 2 days, and I can tell by tomorrow or at latest by Thursday whether or not that bottom disc was indeed a significant contributor of pain. And I can tell you that's just not possible to get in from the left side. Can I get in from the right side? It's quite possible I can, because the right side's anatomy is different, and it may be worth a try to do that at some point. But before I commit her to doing that, I would definitely want to get her permission, informed consent, but also I would want to see how much residual pain she has at the L5S1. And I believe it will be there, but it could only, maybe it'd only be 10%, 20%, I don't know. Shot. So at this point we're removing the needle, and for those of you who are watching, you could see it's a lot easier to access the discs above L5S1. The L5S1 is the hardest, and honestly I normally get in there no problem, but maybe 1 in 30 patients I can't access it because they have anatomical features that just don't allow it, like this patient. And it's really not one thing that doesn't allow it. It's really a combination of a high iliac crest, a wide iliac crest, and then of course a steep angle down to L5S1, and then of course short pedicles, any kind of structural anomaly that would restrict access to the foramen. So short pedicles, enlarged facet joints, hypertrophy of the capsule of the facet shot. These are all contributors. Collapsed disc, muscle tightening during surgery. So there's a large number of physical characteristics and things that are going on that would definitely affect access to L5S1. So be aware of that if you're interested in doing endoscopic surgery someday of the spine through the foramen. In the lumbar spine in particular, there are definitely challenges to getting into L5S1 in particular, which normally I don't have any problem. but I'm telling you, there's a few transforaminal spine surgeons in the world in the year 2021, which is this year, and most of them do not do L5S1. They don't even try because it's too hard to do. But we do it here at Deuk Spine, and like I said, 90% of the time we won't have any, or more than 90, probably 95% of the time we don't have any issues getting in. But in this particular patient, I could not do it safely. So, you know, do we have any questions from our audience? You know, then that brings up, no?
Yes, there's a Facebook viewer who is wondering, can you fuse a spine with a muscle graft instead of a bone graft?
All right, so can you fuse a spine? The question from Facebook was, can you fuse a spine using muscle graft instead of bone graft? The answer is no. Muscles don't fuse the spine. You need bone to fuse the spine. Now, it's a great question because in the news recently was a story about one of the companies that manufacture bone graft for spinal fusions. It has contaminated with tuberculosis bone graft, and they're in a lot of trouble right now because of that. There's a lot of people who are hurt who now have tuberculosis as a result of the bone graft being contaminated. And I mean, this company is going to try to hide its responsibility. She's moving a little bit, but I'm okay with that little bit of movement. Is that it? Right there? All right. So the fact is that clearly when companies harvest bone graft to use for spinal fusions, they must do extensive testing on the patients that they're harvesting, the dead people they're harvesting the bone graft from. And the fact that tuberculosis was infecting the bone graft is shocking because, number one, there's very few people in the United States with tuberculosis. And if they do have it, it's usually immunocompromised people. But number two, so that brings up questions about where did the bone graft come from? You know, is it even from the United States, or where is it from? And was it from a population of people that have a lot of tuberculosis? So automatically I'm thinking like third world countries, you know, and then brings up the question of, well, did they even harvest the graft from, you know, ethically and properly, you know, because there are third world countries where unfortunately people's bodies are being sold to the highest bidder, etc. So these are bad things that we don't want. But bone graft is supposed to be harvested responsibly under very strict guidelines about checking the donor to make sure that they don't have communicable diseases. I mean, there's a lot of testing that goes in, right? Checking for certain viruses, bacteria, microorganisms to make sure that you don't pass that along. Then there's a second level of defense, which is processing that bone graft to make sure it's sterile. And clearly that didn't happen either. So there was a breakdown on multiple levels of bone graft for fusion by that company. And to be quite honest with you, it sounds incredibly irresponsible. So I understand why there's so many people angry about it. But no, you can't use muscle graft. And the bone graft that I primarily use is the patient's own bone. So I'm not introducing anything new into their body when I do fusions. I use their bone primarily. I do use a little bone extender. This is a herniated disc. Now, I want you to look at this thing. This is soft and gooey. When we looked at the x-rays and the MRI, you look at that disc and you go, there's no disc left. There's no soft gooey disc, but yes, there is. You just can't see it, but it's there. I mean, look at it. Let's get a picture of this. John, come into the operating room, get the light on. And not come into the operating room, but go ahead and look at this herniated disc fragment. Can you see it? John, can you go to the eye in the sky?
Yeah, I'm in the eye in the sky. Where should I be focusing on?
Can you see this big thing?
Yes, we can.
You see it? Zoom in on it. Do we have a picture of his eye in the sky, what he's seeing? Just give me one camera. All right, good. Yeah, that's a good size herniation right there. Louise, put your finger there so we have a scale. Look at the size of that thing. All right, that came from that disc. All right, take it. So a lot of people would say, oh, you have a degenerated disc, but there's still a herniation there, okay? There's still nuclear material in there. What is that noise? Do you need some help? All right. So it's a little hazy because there's a lot of dye inside the disc, and now we've gone into it, and some of that blue dye is just leaking out through the irrigation up the tube. But to answer the question from Facebook, you cannot do a spinal fusion or any fusion using muscle. The only thing people do during spine surgery with muscle, if you do a muscle graft, is repair a spinal fluid leak. Okay? So if you have a spinal fluid leak during surgery and the surgeon sees it, then what they can do is take a piece of muscle called a muscle graft and they put it over the spinal fluid leak after they repair it with some suture, if it's possible to repair. And there's different kinds of spinal fluid leak, but one type can be repaired by reapproximating the dura, closing it, and sewing it together. The other kind, if you have like what's called a stellate complex laceration of the dura, then you're not going to be able to sew it together. All you can do is use some fiber and glue, and then a muscle graft, maybe a dural patch, and try to seal it off. But muscle grafts during spine surgery are only used for closing off spinal fluid leaks, generally speaking. I can't think of an exception to that, but maybe there's one that's not coming to my brain right now. What other questions do you have from the audience?
That is all the questions that we have
All
at
right,
this time.
good. So if you have more questions, feel free to type them up. So to summarize, this patient, we were here to do 2 discs. Unfortunately, I could not get into the first one, the L5S1, so I'm not able to repair that one. I'm going to let the patient know after surgery. Patients always get a copy of their videos too, so they can see what's going on. Grab her. And, you know, I just have to let her know I tried. We tried for a long time, and I just couldn't do it. And keep going was not safe, so I had to make a decision to abort the L5S1 and to move on to the L45, plus the other procedures we're doing. We're doing on her a bilateral sacroiliac joint injection because all this pain she's had in her disc for all these years has caused her to walk bad, and it's actually caused her posture to change. And when people's posture changes and their gait changes, so posture is how you stand and sit, and gait is how you walk. But when you start changing the posture of a patient because of a disc injury that causes back pain, their posture changes then cause other areas like other joints and muscles to start aching because they get injured from bad posture and bad walking. So that's why it's important to address these pain sources right away and not let them keep going for years, because you can start creating more problems based on the way you're walking, okay? So a lot of patients who have had back pain for many years, they don't walk right. They walk with a list. They walk to the side. And as a result, once we fix their back, we have to send them to the physical therapist for what's called gait training, where they actually relearn how to walk properly, straight up, you know? And my God, these are, honestly, this healing from the surgery is quick. Healing from the chronic muscle and joint abuse from walking improperly and standing and sitting improperly and just living life improperly because of back pain that was never treated properly in the first place, those injuries are so much harder to fix than what I do. I'm able to fix the source of the back pain that started, which is the disc, but I can't fix the muscles and joints that are now deconditioned or inflamed and injured as a result of chronic abuse of posture and gait. Does that make sense? John, was that clearly explained, do you think?
I believe so. It made sense to me.
Yeah. So, I'll give you an example. If you have a bad hip, all right, and your hip is hurting you, you're going to walk favoring the other hip and the other side, the other leg. You're going to take the weight and pressure off your bad hip. So what that's going to do, though, is it's going to wear down your knee and your hip on the other side, and maybe even your foot. And then you're going to get problems with the foot on the other side. You're going to get problems with the knee on the other side. You're going to get problems with the hip on the other side. And those problems, that bad posture and walking, end up really being the hardest thing to fix after spine surgery, to be quite honest with you. The spine surgery is easy for the most part. Today we had some trouble getting into L5S1. But if the spine surgery part's easy, the recovery's quick, it's really rehabilitating all those secondary problems that take the longest and are the hardest, because they take a lot of time and commitment. And people want to be active these days. They don't want to go to therapy. They don't want to, rehabilitate slowly. Personally, I injured my left hip playing soccer in high school. And I remember I was the captain of the team. I was a superstar soccer player. I was needed, and I loved soccer. That's what I wanted to do, was play. I was literally the MVP. Scored the most goals in the entire league. And so taking a year off of soccer to let my hip heal and rehabilitate it with therapy for a year, it was so hard to do because I just didn't want to be there. I wanted to be active. I wanted to be on the soccer field. But I couldn't do that until I let it heal. All right, there's that bone spur, and it's not hitting any nerves or anything. We're leaving it alone. The herniation's gone. We got rid of most of that in the beginning. And now the annular tear, I'm just about done debriding it. The stuff at 12 o'clock is a little bit of veins and some fat. You can see the golden fat. It's glistening like little diamonds there. Those aren't diamonds, that's fat. Each of those glistening spots is a fat cell. We call them adipocytes. Anyway, they're not doing anything, so we're leaving them alone. But we're pretty much done here. Yeah, oh yeah, we're done. I mean, I just need another couple of minutes. Yeah, call Dr. Patel. So Dr. Patel, we're going to tag team this patient, and my partner, Dr. Patel, is going to come in and do a needle procedure, basically an injection of the SI joint. And of course, we got the patient's permission ahead of time. She knows the game plan. So he's going to do some injections on her to ease her pain and suffering from a joint that I'm not fixing with this particular surgery, but that joint is acting up because she's let the back pain go for so long that it's changed the way she walks and moves. So now she has pain coming from that joint. Laser off. So we're going to just treat everything while she's here. Going to suck everything down. Okay, it's dry. Scope off. And once again, it's unfortunate I wasn't able to get into L5S1, but that's the reality of caring for patients, that have a lot of arthritis. That's one of the limitations of this procedure, the Deuk laser disc repair that we do. It's an amazing procedure. The patient avoids having an open back surgery or fusion or anything major going on. We do it all with a tiny little cut, but sometimes I can't get into the L5S1 disc. And again, it's a rare occurrence. Here, there's probably been 5 times in 500 surgeries, so it's less than 1%, but it does happen, and it happened here with her. So I'm going to have to break the bad news to her afterwards, but like I said, by the time we're done treating this, we'll probably have about 80% of her pain gone. She's going to have to decide if it's worth trying to go maybe from the other side to try to get the extra 20%. And I'm guessing at 80%. It could be more, could be less. I don't know. With all that arthritis there, though, there's a high likelihood that 5-1 is not moving too much. So we'll just have to wait and see. We'll check on her a little bit later, and we'll see how she's doing. Okay? But in the meantime, I'm putting some pressure here just to keep, I don't feel any hematoma or anything or deep blood clot. I just want to make sure we don't, we probably lost 2 mils of blood. So that's what I'm going to call the blood loss. All right, go ahead and type up your questions for this case. I'm Dr. Deuk Majan, the CEO and founder of Deuk Spine. And you watched us do an L45 Deuk laser disc repair for back pain coming from the lumbar spine, but also she has sacroiliac joint pain, and I don't have a surgery for that. So Dr. Patel is coming in to do an injection to reduce the inflammation in that joint. And she's going to need some gait training after surgery with therapy. So we'll be doing her therapy as well for about 6 to 8 weeks. All right, type up your questions and I'll come and answer them. And we have 3 more surgeries today. So go ahead and type your questions up. Keep the live stream going and I'll be there in a minute.
was probably one of the things I noticed right away, was that like I had some control again, which was kind of cool. You know, you still have that sort of, your brain's relearning where things are again. So now that you're back to getting healthy, it's starting to come back. You're starting to feel like you're able to play. But yeah, I'll play. This song is called Oscar the Grouch Goes to the Movies. So yeah, we're a pretty musical family here. We play a lot of shows. We're in a band called Positive Chaos, and this is my bass. Picked it up a little while ago. We use it for acoustic shows. This is actually our guitarist's acoustic guitar. He actually just moved down here from Connecticut, so it's kind of cool having him down. This is our violinist and my fiance's violin, who has been in the band with us for a bunch of years now, and she's having some fun with that. This here's my acoustic guitar, which we'll be hanging out with later. And then this is our drummer's bassist of all things. So yeah, that's that guy. And a couple months ago, it'd be pretty much impossible to pick this guy up off the wall without some pain. So it's kind of cool that I'm able to start doing that again from here. And I'm waiting for you. So that was cool. Like at this point, I wouldn't have been able to do this, I don't know, a month ago. And now I'm able to play guitar again. So it's kind of nice getting back. And getting the band Positive Chaos back together is going to be pretty fun, and we're really looking forward to it. Thanks, Dr. Deuk. And we know this is the way to live, and you keep on calling my... Yeah, so my name is Dave. Last year I was in an auto accident. It was August. T-bone accident in the area. Suffered some neck injuries. Basically kind of spent some months just kind of dealing with it, then decided to talk to a chiropractor, started looking at it. From there, I did the epidural injections. Those were pretty successful. I was feeling a little better. And then woke up one day early, I think it was March, and I was agony. I couldn't move, couldn't lift my arm, aggravating the bottoms of my fingers, like everything hurt from the base of my skull down to all the way into the very base of my pinky. So it was kind of tough. Like, you know, everything that you did is now different. Like everything hurts, and it makes you irritable. It's like this like burning, stinging pain. So you kind of spend a lot of time like going around things. You spend a lot of time like tiptoeing through what you can and can't do. So I decided it was time to see somebody about it. So I went and found Dr. Deuk Majan. You know, you spend a lot of time going to different doctors' offices for something like this because you don't really know. You're looking for something to fix you. So I actually found Dr. Deuk Majan online. Like it wasn't like a referral sort of deal. So I go into the office and it's bright, which is different. A lot of doctors' offices are dark and they're kind of scary. So you go in and everybody's pretty happy. You're like, okay, this is a change. And you know, you talk to the staff there and they're excited to see you. Not only that, but they booked me the day after. Like I called them and they had a spot for me the next day. That was huge. So, you know, you go in there and you're talking to them, and they're exuding this like sort of air that things are going to be okay. And they send you in, and I met with Dr. Deuk Majan's assistant, Luis, who's a great guy. He started setting me up, and he's going through the X-rays and kind of saying like, hey, listen, this is what you got going on. Dr. Deuk Majan's going to come in and explain it further to you. So Dr. Deuk Majan comes in, and he's got an air of confidence about him. You feel better when he's talked to this guy, and I remember him saying like, you know, you're in trouble. You have some issues here. But as he left, he was like, but we're going to patch you up. And that was the first time that I didn't feel fear in like 3 months. It was the first time that you felt good. You felt like, we're going to be okay. We're getting back to being okay. And that was a huge thing. Like this confidence that he had, this swagger that he had, where he came in and he was like, we're going to patch you up. And that was it. And it was like, all right, that's huge. Like that was a huge feeling. Yeah, when I woke up in surgery, I noticed that it felt like a garden hose had unraveled in my arm. Like I could feel things again, like it wasn't this like wrapped up tight pain. Like yeah, there's obviously surgical pain involved there, but it's, you know, you feel instantly better than you were. And it's kind of this, it's no longer like shooting down into your arms, it just feels like things are starting to heal, like things are back in the order that they should be. They're back kind of feeling the way that they should. So, and that was something I noticed that day. Like, you know, you're a little groggy from the medicine and all that stuff, but at the same time, you feel better, like instantly. If you have neck pain, like, or back pain, anything spinal, like, these are the guys to talk to. These are the best in the business. Like, this is what they do. And yeah, I'd highly recommend them. I would recommend them friends, family, strangers, absolutely. Like, yeah, I would highly recommend Dr. Deuk Machen. And that's the end of it right there. So, definitely. Since the surgery out with Dr. Deuk, I'm able to get back to what I love to do. And that's the best part of it. Like, Dr. Deuk set me on the path to getting back to doing what I love. So that's huge. And that's, yeah, I mean, that's awesome. And I'm waiting for you. Thanks, Dr. Deuk.
Wow.
Cool.
That's amazing.
Thanks. That was probably one of the things I noticed right away was that, like, I had some control again, which was kind of cool, you know? You still have that sort of, your brain's relearning where things are again. So now that you're back to getting healthy, it's starting to come back. You're starting to feel like you're able to play. But yeah, I'll play, this song is called Oscar the Grouch Goes to the Movies. So yeah, we're a pretty musical family here. We play a lot of shows. We're in a band called Positive Chaos, and this is my bass. Picked it up a little while ago. We use it for acoustic shows. This is actually our guitarist's acoustic guitar. He actually just moved down here from Connecticut, so it's kind of cool having him down. This is our violinist and my fiance's violin, who has been in the band with us for a bunch of years now, and she's having some fun with that. This here's my acoustic guitar, which we'll be hanging out with later. And then this is our drummer's bassist of all things. So yeah, that's that guy. And a couple months ago, it'd be pretty much impossible to pick this guy up off the wall without some pain. So it's kind of cool that I'm able to start doing that again. From here. And I'm waiting for you. So that was cool. Like at this point, I wouldn't have been able to do this, I don't know, a month ago. And now I'm able to play guitar again. So it's kind of nice getting back. And getting the band Positive Chaos back together is going to be pretty fun, and we're really looking forward to it. Thanks, Dr. Deuk. And we know this is the way to live, and you keep on calling back. Yeah, so my name is Dave. That was probably one of the things I noticed right away, was that like I had some control again, which was kind of cool. You know, you still have that sort of, your brain's relearning where things are again. So now that you're back to getting healthy, it's starting to come back. You're starting to feel like you're able to play. But yeah, I'll play. This song is called Oscar the Grouch Goes to the Movies. So yeah, we're a pretty musical family here. We play a lot of shows. We're in a band called Positive Chaos, and this is my bass. Picked it up a little while ago. We use it for acoustic shows. This is actually our guitarist's acoustic guitar. He actually just moved down here from Connecticut, so it's kind of cool having him down. This is our violinist and my fiance's violin, who has been in the band with us for a bunch of years now, and she's having some fun with that. This here's my acoustic guitar, which we'll be hanging out with later. And then this is our drummer's bassist of all things. So yeah, that's that guy. And a couple months ago, it'd be pretty much impossible to pick this guy up off the wall without some pain. So it's kind of cool that I'm able to start doing that again from here. And I'm waiting for you. So that was cool. Like at this point, I wouldn't have been able to do this, I don't know, a month ago. And now I'm able to play guitar again. So it's kind of nice getting back. And getting the band Positive Chaos back together is going to be pretty fun, and we're really looking forward to it. Thanks, Dr. Deuk. And we know this is the way to live, and you keep on calling back. Yeah, so my name is Dave. Last year I was in a auto accident. It was August. T-bone accident in the area. Suffered some neck injuries. Basically kind of spent some months just kind of dealing with it, then decided to talk to a chiropractor, started looking at it. From there, I did the epidural injections. Those were pretty successful. I was feeling a little better. And then woke up one day early, I think it was March, and I was agony. I couldn't move, couldn't lift my arm, aggravating the bottoms of my fingers, like everything hurt from the base of my skull down to all the way into the very base of my pinky. So it was kind of tough. Like, you know, everything that you did is now different. Like everything hurts, and it, you know, makes you irritable. It's like this like burning, stinging pain. So you kind of spend a lot of time like going around things. You spend a lot of time like tiptoeing through what you can and can't do. So I decided it was time to see somebody about it. So I went and found Dr. Deuk Machen. You know, you spend a lot of time going to different doctors' offices for something like this because you don't really know. You're looking for something to fix you. So I actually found Dr. Deuk Machen online. Like it wasn't like a referral sort of deal. So I go into the office and it's bright, which is different. A lot of doctors' offices are dark and they're kind of scary. So you go in and everybody's pretty happy. You're like, okay, this is a change. And you know, you talk to the staff there and they're excited to see you. Not only that, but they booked me the day after. Like I called them and they had a spot for me the next day. That was huge. So, you know, you go in there and you're talking to them, and they're exuding this like sort of air that things are going to be okay. And they send you in, and I met with Dr. Deuk Machen's assistant, Luis, who's a great guy. He started setting me up, and he's going through the X-rays and kind of saying like, hey, listen, this is what you got going on. Dr. Deuk Machen's going to come in and explain it further to you. So Dr. Deuk Machen comes in, and he's got an air of confidence about him. You feel better when he's talked to this guy, and I remember him saying like, you know, you're in trouble. You have some issues here. But as he left, he was like, but we're gonna patch you up. And that was the first time that I didn't feel fear in like 3 months. It was the first time that you felt good. You felt like, we're gonna be okay. We're getting back to being okay. And that was a huge thing. Like this confidence that he had, this swagger that he had, where he came in and he was like, we're gonna patch you up. And that was it. And it was like, all right, that's huge. Like that was a huge feeling. Yeah, when I woke up in surgery, I noticed that it felt like a garden hose had unraveled in my arm. Like I could feel things again, like it wasn't this like wrapped up tight pain. Like yeah, there's obviously surgical pain involved there, but it's, you know, you feel instantly better than you were. And it's kind of this, it's no longer like shooting down into your arms, it just feels like things are starting to heal, like things are back in the order that they should be. They're back kind of feeling the way that they should. So, and that was something I noticed that day. Like, you know, you're a little groggy from the medicine and all that stuff, but at the same time, you feel better, like instantly. If you have neck pain, like, or back pain, anything spinal, like, these are the guys to talk to. These are the best in the business. Like, this is what they do. And yeah, I'd highly recommend them. I would recommend them to friends, family, strangers, absolutely. Like, yeah, I would highly recommend Dr. Duke Machen. That's the end of it right there. So, definitely. Since the surgery out with Dr. Duke, I'm able to get back to what I love to do. And that's the best part of it. Dr. Duke set me on the path to getting back to doing what I love. So that's huge. And that's, yeah, I mean, that's awesome. Thanks, Dr. Duke.
Wow.
Cool.
That's amazing.
Thanks. That was probably one of
Sorry about that, folks. I had to go check on the next patient and get that next patient ready for surgery. We're going to be doing, again, lower back surgery for back and leg pain on a patient who traveled from Canada as well. And we had to get everything straightened out there. So we're ready to answer the final questions on the surgery that was just completed. Just to reiterate, the patient we just did surgery on came here for back pain and left leg symptoms of pain, numbness, weakness. So our focus on her was to go to the source of the pain, which was the herniated discs at the L4-5, L5-S1, and the sacroiliac joints and the piriformis muscle. Now, you guys didn't watch the SI joint injection or the piriformis muscle injection, but you watched the Deuk laser disc repair where we repaired the disc at L4-5. I originally intended also to do the L5-S1, but I couldn't get in. I tried extensively to gain access. The problem is quite simply to get into the L5-S1 disc, and you're not seeing the whole picture here, but I'm showing you a spine model. This is the tailbone, the sacrum down here. There's another bone connected here called the iliac crest, and my hand is mimicking it. So I have to literally come from here with that needle to try to get past the iliac crest bone and then work my way into a tiny little hole right there at the bottom of the spine. Forget about the screws and rods, that's not part of the surgery. But that hole right there was being blocked off by arthritis from the facet joint, hypertrophied facet joint, thickening capsule of the facet joint, basically collapse of the disc. As you can see, it closes off this access point. And then the iliac crest was super high like that, rather than being low and out of the way, it was up blocking it. There was arthritis in the SI joint, which was growing backwards. So I had like 6 different anatomical things going on. They were all basically making the little hole that's normally about 1 millimeter or 2 wide to get down to that foramen at L5-S1. It just narrowed it down to nothing. So I tried different entry points. I tried different trajectory, you know, coming top down, coming lower, going more medial, more lateral. I tried a lot of different things in the beginning of the surgery, spent about 20 minutes, but I just couldn't get in there. So, you know, you could try to force your way through a different path, but you're going to end up getting into something you shouldn't. So I gave it a fair try. I think the patient will do very well because we've treated about 80% of her pain through the other stuff that we've done. The question is, will the residual pain at L5-S1 be significant? And is it going to be enough to make her want to get something done about it? You know, something perhaps going on the other side or doing something open. I don't know yet. We're just going to have to wait and see how she's doing. Well, we'll have a better idea in a few minutes. Okay, do we have any questions for this surgery?
Yes, so one Facebook viewer is one that they state that they've had a vasectomy and laminectomy, but they still have some bulging discs. Is the DLDR still an option to treat that?
Great question, John. Thanks for asking. So one of our viewers says, you know, I've already had treatment for my back pain, I believe, which was a laminectomy where they removed the bone and part of the facet joint, but they really never addressed the disc problem. That's correct, and yes, you are a candidate for the Deuk laser disc repair. The Deuk laser disc repair surgery that we do is not a laminectomy. There is no laminectomy done. There is no partial facetectomy, removing part of the facet joint. There's no destruction of the spine. And the Deuk laser disc repair doesn't do what a microdiscectomy does. It's different. Microdiscectomy's job is really to go in, remove all the bone and ligament back here, which is bad, but really to unpinch the nerve coming out of the hole. And the way we do it is we get in there, we make a hole, and then we kind of go in and grab pieces of the herniation with a grabber as much as possible. It is a terrible surgery. I don't do this surgery anymore because it's very ineffective and very traumatic and damaging to the spine to get there. And frequently it doesn't address the source of back pain, but frequently the leg symptoms come back or stay because they didn't do a good decompression. With the Deuk laser disc repair procedure, we come in with an endoscope. As you pull the endoscope out and use the laser to remove the herniation and clean the annular tear, you can actually see the herniation's gone. You can actually see the nerve roots completely decompressed, and the disc is repaired. So yes, you can still have the Deuk laser disc repair done. That's the great news. Give us a call or contact us, submit your MRI, we'll review it, and the Deuk laser disc repair procedure should still work to eliminate your back pain. Okay? Next question.
That is the last question we have.
All right. Sorry to keep you waiting. I hope you obviously fast forward through the dead zone from the surgery to now. And we're going to have 3 more surgeries for you today. All right. Nice talking to you.